Okay, so a few people are still coming into the room here today. So welcome everyone. Welcome to our Alls Ed virtual education program. My name is Kara Murgatroyd. I am the education team lead and counseling therapist with the Society. We're super excited to be able to connect and learn with you today. If you happen to be experiencing any trouble, send us a message in the chat box to the ASNS Zoom support, and they'll try to help you through it. For today's sessions, just to note that all participants have been muted and your videos have been turned off for your privacy, because this will be recorded and added to the Alzheimer's Society of Nova Scotia YouTube channel so that folks can see it at a later date. Yeah, so with these privacy measures in place, we'll be just, again, to note that we will be recording this session and it will be up later on our YouTube channel. So, Jen, if I could get you to flip through to the next slide. Down on the bottom, I think,
I'm not
Jen,
sure why it's not moving.
could be just the on the bottom of your screen, the bottom left corner. There may be an arrow there to the right or to the left, possibly.
Let's see it.
Just take a second. And every once in a while, we have these little tech issues, which is to be expected, which is fine. Oh, there you go, Jen. See at the bottom left corner. There, perfect.
Yeah,
Thank you.
there we go. Sorry about that.
No worries at all. So as we begin, it's important to acknowledge that we are in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq Nation. We are all treaty people. The Alzheimer's Society is committed to undertaking work to create collaborative and respectful relationships. And really, together, our goal is to identify and develop tools that align with the beliefs and needs of Indigenous, African Nova Scotians, Acadians, and all equity-seeking communities across the province. And if we could just flip to the next one. The work that we do at the Alzheimer's Society of Nova Scotia, it's actually, we use an acronym. I'm not going to worry about the slide right now, but we use the acronym IDEA. And it's really, with us at the Alzheimer's Society of Nova Scotia, it's looking at becoming a more diverse and inclusive organization where all Nova Scotians feel a sense of belonging. So we use the acronym there that you see on the screen to represent inclusion, diversity, equity, and accessibility. And what it means is it's really applying a person-centered lens to the work that we do and ensure that we're fostering a sense of belonging in all that we do. So thank you all for joining us this afternoon. Our audience today includes people living with a diagnosis of dementia, people caring for a person, a family or friend member. We have healthcare professionals and students and people who would like to learn more about dementia. So the presentation today will be approximately 30 to 35 minutes, and we have about 15 minutes for a question and answer session. So please feel free, if you have questions, to ask those using the private chat box, and that is directed to the ASNS Zoom support. Questions will only be seen by ASNS, and we'll get to those at the very end of the presentation. So I'm super excited actually to be able to introduce our topic today. It's understanding dementia behavior, and I've had the pleasure of working with both Marianne Johnston and Jennifer Loucks. And so welcome this afternoon. Just to give you a bit of background, Marianne and Jennifer Loucks are behavior resource consultants with the Continuing Care Behavioral Health team. Marianne is one of 3 behavioral resource consultants in the Northern Zone, covering Pictou County for over 15 years. She's a registered nurse with a background in mental health and applied behavioral analysis. She's worked for over 30 years supporting adults experiencing impaired cognitive function with behavioral expressions. And welcome to Jennifer. Jennifer is the Behavior Resource Consultant for Cumberland County, one of 3 covering the Northern Zone. Jennifer has worked for over 20 years as a recreation therapist in various communities in New Brunswick before coming to this role as a behavior resource consultant in 2018. Jennifer's experience lends itself to her current role, having worked in mental health and addictions, geriatric and veterans programs, leadership in long-term care, and a coach for the long-term care sector in New Brunswick for nonviolent crisis intervention, GPA, and You First. So Jennifer and Marianne will provide an overview of the PIECES program, which is it's a PIECES framework, which is really a guide to help us understand why behaviors happen with dementia. So welcome, Marianne, and welcome, Jennifer.
Thank you, Kara. We're very happy to be here today.
Thank
Next
you.
slide. Next slide, Jen. There we go. So our objectives today are looking at a bit of an introduction to the continuing care behavioral health team, parts of what our role are, having a look at the overall cognitive changes. So what we're going to be reviewing is what is called the 7 A's of dementia. And this helps us a lot to pinpoint what is contributing to a person's behavioral expressions. And then around the end of it, we'll look more at the PIECES framework itself and how we use that to identify the possible contributing factors. So this is kind of what we look like. There is 11 BRCs across the province. Here in the northern zone, there's myself in Pictou County, Jennifer in Cumberland, and Sandra Henneberry, who is Colchester and East Cumberland. In Eastern, we have Brenda Etheridge, I hope I'm saying her name right, Leona Wilnuff, and Victoria Jessam, and they would cover from Antigonish, Guysborough down through Cape Breton. Central Zone, we have Linda Cully and Mary Stanley, and they cover all of Halifax area. And the Western Zone, we have Karen Bennett, Corinne Smith, and Angie Wenzel, and they cover South Shore Valley and Southwest. So there is a BRC, or Behavior Resource Consultant, attached to every facility across the province. To access us, any of the facilities can access us directly. If you are living in the community, you would contact your care coordinator, who would then pull us in. Or if you were in the hospital, then you would have the hospital-based care coordinator, who would then contact us. What our role is and how we can help, we do formal education. So we have the PIECES program itself, and that is for registered health professionals who are responsible for the development and the implementation of individualized care plans. We also facilitate the gentle persuasive approach, and we have a real dynamic learning platform right now, Embodied Labs, which is web immersive, and basically you embody a person who is going through the journey. So you get that first person perspective of dementia. And we also help facilitate the You First with the Alzheimer's Society. We also do informal education. So very hard sometimes for staff to get away from their work. So a lot of times we do coaching in the moment, but we also do kind of mini education sessions that can go anywhere from 15 minutes to a half hour, depending on what the need is or what the topic is. When it comes to the consultation role, we do what we're called case-based consultations. So we're not actually doing an assessment. Our role is very unique, and we're very lucky because we have a very diverse team. So on our team, we have social workers, we have occupational therapists, recreation therapists, as well as registered nurses. So one of the things that's very great about that is if, we come up against a challenge that we're just not sure which direction to go, then we can bring it to the team for a fuller discussion and have many different lenses looking at what the concern is. So our case-based consultations, basically that is to meet with the team, because that's the other thing about our role. It's very unique in that we are not serving the person that is receiving the care. We are here to support the care teams and care partners of that person. We also try to set up monthly behavioral health meetings with all of our stakeholders in our facilities. And we also assist with transition care planning. So when we have somebody in one environment and they are going to be transitioning into another one, we will, and there is a lot of complex behavioral expressions involved, and we will come in with it and try to work with everybody to get a really nice, tight transitional care plan in place. And the other side of our role is the capacity building, which is basically we're looking at pulling our teams together and collaborating with each other so that we are all sharing the care of the person. So a person with dementia may certainly experience changes in memory, judgment, attention, mood, communication, abilities, or the ability to complete activities of daily living. The one message we want to get through today, if nothing else, is that all behavior has meaning, and it is a form of communication. The person is responding to something, whether it's something negative or frustrating or confusing in their environment. Behaviors do not occur in isolation. They're always in context to an unmet need or a stimuli. The stimuli itself can be external to the person. It can be something that's happening in the environment, or it can also be internal, because a lot of times, people will be feeling frustrated and bored and just that unsettled feeling, and they have a very hard time describing that. The other thing is we want to really clarify is a person's personhood remains throughout the dementia experience. So we want to look at the whole person, and that's exactly what the PIECES acronym is all about, is making sure that we look very holistically and comprehensively at every aspect of the person, and basically making sure that no stone goes unturned. So one of the things we're going to touch on today and focus on is the cognitive changes that happen when a person is experiencing a neurocognitive illness. And that is usually represented under the I in PIECES. And as I have referenced, there are a few A's that help us kind of pinpoint where the cognitive changes have occurred. And it gives us a better understanding to what the person is dealing with. The other thing I wanted to mention too, when it comes to behavioral expressions, is sometimes, and we may not mean to, but sometimes a person can be reacting to us and the mood we're in and how we present ourselves, because we do set the tone. And, if we're having a frustrating day or we're getting a little frustrated trying to get a task done, then the person's going to pick up on that and they're going to feel that. And, one thing as human beings, we do tend to leak our emotions. So it's always trying to find that balance of, deep breathing, if that's what it needs, or even stepping back a bit and then coming at a situation again. So one of the first days we're going to look at is amnesia, which is the loss of memory. And some of the things that you might see is difficulty to learn information and poor short-term memory. And poor short-term memory certainly is kind of a hallmark when it comes to Alzheimer's. The person can't learn consciously, but can still learn on an unconscious level. So if you think of yourself today and some of the tasks that you have performed, they're in what's called our procedural memory. So this is something we can still tap into as a person is struggling with these losses. One of the best and most important things to do for somebody is consistency. And I know that's very hard when you're giving care, but consistency is so important, and routines. So basically, the person develops that procedural memory, if it wasn't already there for them, around what to expect through the day, because it will be changing on a continuum. It does continue to change. So visual cues, validating and non-confrontational approach, that's going to be a huge one for people. I know it's really hard, but a lot of times when a person does become responsive towards us, from their perspective, they're seeing us as trying to control them. or confront them, or even sometimes bring them back to reality. When we're not realizing that their reality is not the same as us, they are here in the here and now, but memories they're pulling are from the past. And what we really need to do is meet them where they're at, not try to pull them to where we are. So another one of the A's is aphasia, which is the loss of language. That can be either receptive or expressive. So things that you might see, the person becomes a little more quiet, speaking less, difficulty getting words out, not being able to follow written instructions, or may appear uncooperative, using the wrong words, like I would like to brush my shoes. When I think of aphasia, one of the things I think that is so important is the receptive aphasia. A lot of times, because a person is still able to speak and express themselves and tell us what they want, we assume, something we should never do, but we assume that they understand what we are saying to them and that they're able to process what we are saying. And that's not always necessarily true, because there's two different areas of the brain where communication is involved, right? The frontal lobe and the temporal lobe. So we could have somebody who is able to communicate verbally quite fine with us, but is not really able to process what we are saying to them. Some of the strategies we can use: gestures, body language, visual cues, like, objects or pictures. It's very important to take it one step at a time, and definitely continue to observe their body language closely to see if they are understanding. But if somebody is struggling with receptive aphasia, and we give a multi-step task type thing to them, they're probably just going to go with the last. So if I walked up to somebody and said, okay, it's bedtime now, so let's go get our teeth brushed, face washed, your slippers off, and into bed, the person may go as far as put the slippers off and into bed. The other steps would already be gone for them. So one step direction is really important. Apathy is another A, loss of motivation or initiation. And there's actually two types of apathy. There is the apathy when it's a cognitive impairment, which is the one we'll talk about right now. And it's some of the signs you may see is the person will sit in silence, but will perk up and respond when you approach them. Or they may not know how to get started, get a activity started. And even something like eating a meal, you might see somebody sitting there and have not touched their plate. That could be apathy. So if you were to go hand over hand with the utensil and bring it to their mouth, then they would probably engage and continue on. Unless, of course, it is the apathy that comes with the depression. If it's apathy with depression, no matter how much you try to initiate, the person will not engage with you. Some of the strategies is to take a more assertive approach, instead of saying, would you like to? Because 9 times out of 10, they will tell you no, simply because they don't understand. It would be much better to say, let's go, it's time for dinner, or let's go down here to see the show. Usually the person will then get up and come with you. And you need to help them get started and provide your verbal cues for them. Alter perception, which is a change in visual field. This is actually a really big one, because the person loses their depth perception and they have visual distortions that happen. So it definitely will increase their anxiety and fear, because they lose their 3D versus their 2D. So if you have somebody who really resists getting in a bathtub, something you want to consider: is there a change in their perception? Excuse me, has it altered? Because what happens is they see the water, but they're not able to see the bottom of the bathtub. So for them, it's like, you're going to put me in there and there's no bottom. So it's definitely going to provoke fear. Excuse me. The same with darker patches on your flooring and things like that, that can basically look like a hole in the floor. So some of the strategies to look at is in the environmental adaptations, like your flooring, your lighting, removing clutter, high contrasting colors and cueing. We will often hear that somebody is urinating in the wrong spot, but if you walk into a bathroom and the walls are nice and light and the toilet is all white and the toilet seat cover is white, the person may not be able to see that toilet. So if you put on a black toilet seat cover, a red toilet seat cover, something that would really contrast and stick out, you will have more success with having your folks go to the bathroom. Agnosia. So that is difficulty recognizing people, objects, and sounds. Signs you might see: mistaking a comb for a remote control, or not recognizing familiar faces. And that's the hardest one for family members, is when their loved one loses that recognition. Trying to drink hand sanitizer or use it as a face cream. It impacts the ability to recognize objects through sight, sounds, and touch. And some of the strategies that you can look at is to, remove any unsafe objects from the environment, mimic the use of the object for the person, support families' understandings if they can't recognize faces. And mirrors can be so triggering, and it's amazing over the years how many times I've heard a person say, well, that old woman's always in that bathroom watching me. So they don't recognize that it is them in the mirror. So that can be very traumatic for a person as well. So sometimes we have to remove mirrors or cover them up. Anaprexia, which is the loss of purposeful movement or sequencing. Excuse me. So what you might see is someone putting clothes on in the wrong order, spilling food when eating, pushing against staff when trying to do a task. Some of the strategies you can use is to have things arranged in order and break down into small steps. So when you really think of the tasks that have to be performed, like even getting dressed this morning, there are multiple steps in that. So almost doing a task analysis and breaking it down each step by step, and then putting it in order for them. So sometimes even just drawing it out or laying out a picture in what sequence it has to be. Because one of the most important things that we want to do is to ensure that we're doing with the person, not to the person or for them. So to keep their independence and to be, part of the care team and help to actively be engaged in their care. It's really important to put things out step by step, small steps, and just to support them through it. And I talk quick and fast, so I'm going to pass it over to Jennifer now.
Thanks, Marianne. All right. So one of the other A's that is often experienced is anosognosia. And this one can be a challenge because the person is not aware that there's anything wrong with them. They have poor insight to what they may need help with. They may refuse help. They may be unaware of where they are. Although they're living in the moment of the time today, their memories are in the past of past memories. And a good example of this was a gentleman that we were supporting in a facility. He would go, I would take time to get to know him and go into his room and look at his pictures with him. And he would look at a picture of himself with his son who was younger. And he would identify with the young man in the picture, saying that that was him, when in fact, looking at the picture, you knew that the older gentleman was him. But his awareness at that moment was that his mind was back in a past memory. And so sometimes when we approach someone that is experiencing poor self-awareness of the fact that they're, 80 years old, they're living with supports at home or in a facility with supports, that we can't change that thinking, and we have to enter into their reality and kind of support them where they're at. And in order to get them to maybe participate in tasks that they don't think that they need help with, giving them choice, or, tying, getting ready for the day to an activity that you're going to enjoy together with them, are often times that you can encourage someone to participate in care, even and allow help in that instance. So that can be some of the more challenging moments that we often hear from staff is, how do you support someone that doesn't want your help or doesn't think that they need the help? So it's really about validating where they're at and trying to get an understanding of where their mind is at in that moment. And I will often say to staff that struggle with this one is to when you stop and take that extra time to build rapport, you get a better sense of where the person mind or mood may be in that moment. One of the other A's that we're going to mention, but with the Pieces program, we don't incorporate this as a change because it's associated more with delirium. So when a person who has an attention deficit has an inability to keep focus, or their focus shifts, they might be the person that has difficulty sitting still or sitting down for a meal. They may be up and down all the time. But what happens is the brain gets stuck on repetitive action. And so it can be difficult to complete a task with a person that's struggling with attention deficit. But the more important point about attention deficit, it is a definite sign that there could be something else going on with the person. If they're having delirium is a medical emergency, so we need to make sure that we're ruling out that there's any physical reason, like an infection or a drug interaction or anything like that, that's causing a change in that person, that's putting them in an acute state where they need to be seen by somebody medically. We still do see people that have attention deficit challenges when they're living in a home environment or in long-term care. And we will often suggest to staff that they encourage, rest periods for that person, because they might be the person that's constantly walking all the time or going in and out of rooms. And so we've also suggested having a wandering cart, giving them something useful that they can push while they're walking. And at the same time, putting a plate with some finger sandwiches so that we know that they're still getting their nutrition because they won't sit still in the dining room for a meal. So those are some of the ideas that we share with staff. When you have someone that's struggling with keeping focus, or their attention is all over the place, and it's really difficult to get them to sit still and have a resting time. One of the reasons why we wanted to talk about the I's in the Pieces acronym is we really feel, and I speak from a personal point of view as well, I have a husband that was just diagnosed with a mild cognitive impairment. So we're on this journey now of what dementia he may be dealing with as we get to know the different things that he's dealing with. But the reason why I mention that is that oftentimes we can't look inside somebody's mind and see the changes that they experience, those cognitive changes. So what we do is the Pieces education that the behavior resource team provide. It's an education opportunity for any of our staff that are registered staff. So our RNs, our LPNs, our allied health professionals. And what it does is it's a holistic approach, looking at the entire person and all the things that could contribute to a change in a behavior. As Marianne mentioned earlier, Behavior happens for a reason. The person is trying to communicate something, and because of the experiences they have or the deficits they're experiencing with their diagnosis, they may not be able to communicate that clearly with us. So what we do with pieces is we educate our staff, because they're the ones that are going to go back to the team and help to determine what is contributing to those changes and what strategies and implementations do we need to put into the care plan that we're directing all staff to follow when we're approaching, working, and trying to support that particular person that has complex needs and has responsive behaviors. So pieces is really formed around what we call the 3-question template. So as I mentioned, it's holistic in that we're looking at the entire person, and we're looking at all the care partners that are involved in supporting that person, including family members. So our strategy is that we are supporting people with complex conditions that have behavior changes, and we want to gain as much knowledge from family and from other care partners that have been working with that person day in and day out. What Pieces does is it provides a common language and a common focus when we're trying to attempt to discover what may be contributing to the behaviors, because that can be a really overwhelming task for staff or for family members that are trying to really figure out, why is my loved one, why is the resident that I'm trying to support, why are they having behaviors, and what do I need to understand more to really help them? So Pieces is really based on evidence-informed assessment, and it's a team collaborative approach, so that we're all following the same kind of language, and we're all together working to try and determine what strategies would best support someone in their unique care plan. So we actually just finished day 1 of Pieces education yesterday for our Northern Zone staff. So if my voice shorts out, and I know Mary Ann's having some challenges too, it's because we spent the day speaking yesterday. So apologize if I sound like my voice is a bit rough, but so we will deliver the Pieces education, as I said, to our facility staff that are registered, but we also provide it to our home care staff, our nurses and LPNs that are working in home care, and as well our care coordinators in continuing care. Because again, it gives us a frame of reference as a team member to have those conversations to try and determine how we can best support a person with complexities. So as I said, the 3-question template is really key. So we're looking at, what are the behaviors of concern? So what are in the moment of meeting a person and sort of working through the assessment process? We really want to prioritize, what are the behaviors today in this actual moment of meeting this person and talking to the staff or the family members. What are the behaviors that are of great concern? And from that, we identify those behaviors, and then we go through the process of looking at, are these behaviors a risk to the person or to others around them? And then we break down our Pieces acronym, which we'll get into in a few seconds, about what could potentially be contributing to why there's a change in that person and why they're having responsive behaviors. And then as we gather as much information, we might decide that we need to do further investigation. We may need to do some assessments. We might want to gather more information from family, or we might want to talk to staff around particular incidents that have clearly shown that there's some evidence of responsive behaviors. And we want to try and understand what might have triggered that person and what's contributing to it. And from gathering all that information, doing further assessment, we can then put into place strategies and interventions for the care plan that all staff or all home care staff can follow to best support that person. So right now I'm going to go through the acronym of Pieces. So when we look at our first, I mentioned delirium earlier, but what we want to do is rule out that there's anything physically going on with the person. Is there an infection? Is there anything that is causing them acute problems when it comes to their medical conditions? We know that a lot of the senior adults that we work with have lots of different complexities they're dealing with. They may have a background with diabetes and cardiac issues on top of their dementia. So we really want to flush out, is there something that we've missed that's actively contributing to their health? And so we want to rule that out, number one, because delirium is a serious condition that older adults experience. So when we talk about physical, we talk about the 5 Ds. So pain or discomfort. We talk about drug interactions, because we know that drugs that a person is taking and over-the-counter medications can sometimes not mix well. We can talk about sleep. We talk about a person experiencing problems with their bowels or their bladder. All of those things can certainly factor into a reason why a person may be having responsive behaviors, because it's of a physical nature. The second part, and Marianne, jump in if I miss anything, because I know this is all fresh in both of our minds, but certainly don't hesitate if I miss anything. The second piece is the I, which Marianne and I spent quite a bit of time reviewing with you, the A's of dementia. So those are the cognitive changes that a person experiences and the deficits that come with those changes that we can't see that are going on in the brain. But we know that when a person attempts to do a task, like baking, like driving a car, that those processes that are have many steps to them can be very difficult to carry out for someone who has some changes in their cognition. So we see the changes to memory, as Marianne had mentioned. Problem solving, word finding is a big change, and often an early change that we see. I know my husband has a real challenge with, he's very vague when he talks to me. He says, that thing we did yesterday, that was really good. And so I have to decide, do I want to flush out what that is? Or do I want to just agree with him and his reality and carry on? And sometimes I can flush out what that is, but sometimes it's best to just leave it alone and agree with what he's saying and try and figure out eventually what he really, the words he was trying to put together to form a sentence so that I understand. But some of those challenges can absolutely frustrate someone that has dementia when they are unable to understand what you're saying, like going too quickly, which I do. I teach this stuff and I'm learning it as I'm living it as well. But you know, it's taking that time to slow things down, because in our world, we're always working on, fast forward, really fast, getting tasks done, getting things done. And a person with dementia, their mind just cannot grasp everything all at once. So we want to identify if there's some real changes there that are impacting, contributing to behaviors. The E is the emotional changes. There's so many life changes that a person experiences when they have dementia. They may have to relocate to from the home that they've lived in for 40 years. They may have lost family members or their spouse. There's been a lot of changes in their health. So maybe they now have to use a walker. There's new people that are in and out of their lives every day, trying to help doing their care for them and with them. And so those things are really can cause a lot of changes for a person, and could cause and attribute to anxiety and depression and some of those more difficult experiences that trigger some of those deeper experiences emotionally, that it can be very difficult for them. And so we want to look at a person's mental health history. Do they have a history of anxiety or depression? And then, is this something new for them? How many changes or life changes are they experiencing? Maybe they lived on their own and now they have to share a room with a roommate. Some of those changes can be quite significant and could affect and impact the way that they're responding to things around them. So that's the emotional piece of things. Then we would look at the C, which is the capabilities. So what are the strengths and abilities that still exist for that person? Everybody has a story, everybody has interests and meaningful relationships and activities that they've done in the past. And we want to try and support a person by being able to adjust those things so that they can still enjoy them, and still be a part of meaningful things. And so when it comes to care, when it comes to choices and things, we want to be able to give them the most independence and autonomy to make choices, but at the same time supporting them in a way that doesn't make them feel like they can't do things anymore, or that they don't have things that they can do anymore. And I think that's a huge piece that we miss sometimes, because, and I see it again with my husband, he can't do simple tasks anymore. And for him, it's really frustrating and it's embarrassing and it's difficult. And that's when I'm probably going to get pushback on things, or he's not going to want my help because he's embarrassed that he can't do it. And so when we identify some of those challenges that a person has, if we can figure out how to best support that independence and maintain some of those interests in meaningful things by adapting them or adopting new ways of doing things, that can certainly help support them. And then environment, Marianne alluded to this earlier as well, that our environment, because of the visual spatial changes, so some of the cognitive changes that happen, some of the physical changes that people experience, can impact their environment as well. Maybe the environment is not set up properly to give that person success in being able to be supported properly. If they have to use a walker now, maybe we want to put a cue or a reminder on their walker for them and remind them by cueing them to say that they need to use that to get around. Is their environment set up for that, for success? We know that the color of the environment is often sterile, like white and white furniture, white walls, white floors. That can be really difficult for somebody that has visual changes with dementia. So we want to try and set up the environment to help that person be as successful as they can. As we age, our vision changes. Getting around and knowing where places and people are. Where's the bathroom? There's often people that are roaming or walking through a facility trying to figure out where the bathroom is because they just don't know what the word means, or maybe they're better with a visual cue. So if we can set up the environment for success. I remember supporting a young lady who was trying to care for her mom at home, and she wanted to put the dishes away. And she would put the dirty dishes in with the clean dishes. So I said, why don't you put the dirty dishes in the dishwasher and just close it up, and just have the dishes set out that she can wash in the sink and dry, and then put them up in the cupboard, and label your cupboards where things go. So that's a cue or a reminder for where things go. The other thing is, get rid of all your glassware and put in plastic glasses and plastic plates, so you don't have to worry if something gets broken. So some of those things that we can change in the environment to still help that person maintain independence is really important. And then finally, the S in pieces is the social and cultural pieces about a person that we need to know about them in order to support them in their unique needs. So, there's lots of people that have different interests, different life stories. I would often say to people that you don't find out about the best side of people till you read their obituary. Let's find out those things now and incorporate that into their lifestyle wherever they need to be supported best. So if we can find relationships, ways to connect with them socially, engage them in activities that they used to do in the past, maybe they can't do it the same way, but if we can adapt them to be able to still enjoy those things, it's so important. Because we have seen, and I can think of 2 of my facilities right now where we don't have recreation, or we don't have, people that are there to engage our residents in activities, or maybe home care doesn't know the person well enough, or doesn't know what their interests and likes are. They don't know how to engage them well. So sometimes that can be very frustrating and really take away from a person, and that could upset them and result in responsive behaviors, because their capabilities are not being met through the social opportunities or the cultural opportunities that they may need to express. So that's kind of pieces as a whole. And then we thought we would give you a case example of how we might address someone who's part of our continuing care family that, you know, this gentleman, Harry, it has services with continuing care. He has the VON, helps with Meals on Wheels. He's a 78-year-old gentleman, lives in a senior's apartment. His daughter, who's involved in his care, lives 2 hours away. He has a family physician. We know that his medical history includes Parkinson's disease. He has COPD, rheumatoid arthritis, and osteoporosis. And he receives Meals on Wheels and uses a walker. So some people have shared some concerns. They've seen some changes with him. So they're seeing that he has increased confusion and he's unsteady when he's walking. The volunteer that delivers the Meals on Wheels is concerned because they've seen empty boxes or boxes half emptied on the stovetop. They smell a strong smell of urine in the home when they go to deliver the meals. They don't think that Harry's really getting the proper nutrition value from the meals because there's often packages left. And so they've shared their concerns. And then the daughter, when she was visiting, shared concerns around his poor hygiene and nutrition. And she also noted that she saw a broken lamp with a spliced cord on the carpet. So we might get a call from our care coordinator to say, you know, could you help us to determine what might be going on that's contributing to these changes that Harry is experiencing? So what we would do is do further investigation with speaking to the family, the home care staff, anyone who's supporting Harry in the community, to see what is Harry's baseline, like what's Harry normally like? Is this a really significant change for him? Because sometimes what happens is when behaviors happen, we could rush to the wrong conclusion that, oh, he must have dementia. It must be getting worse. He needs to be placed in long-term care. But we don't want to go there yet because we really want to support Harry in the best possible way that we can. So the situation can change depending on what's going on with his health concerns. So we find out more information about Harry. We find out that 6 weeks ago, Harry developed a severe chest cold and has a persistent cough. I think I'm going to be sounding like Harry soon. Last month, he visited the ER and he had severe shortness of breath. And we know he has COPD, chronic obstructive pulmonary disease. So he has a history of difficulty with breathing. He was experiencing dizziness, was diagnosed with an upper respiratory infection, and he was experiencing dehydration and weakness because he wasn't probably eating and drinking, because most of us don't want to eat and drink when we're really feeling unwell. For somebody like Harry who has other health issues, that can lead to further problems. We know that Harry's baseline, from talking to his daughter, talking to the people in his community, that he was always attending the men's group in the seniors complex, and he loved going on the social outings. So he was a pretty active guy, and he regularly connected with his grandchildren through the use of the iPad. So by knowing his baseline, we can flag what are some of those significant changes that were not normal for him, right? So we know that he had a severe chest cold with the cough. We know that he has COPD history, but he also, because of the cough and chest cold, has really developed difficulty breathing. And as a result, with that infection, it's further weakened him because he's not eating and drinking. So with the question 2 of pieces, we would then go through what are the contributing factors. So we want to rule out, as we said earlier, if there's any physical reason why this would contribute to Harry's change. And we have identified here that there was a history of challenges with respiratory infection, and we know that it continues to be evident. So therefore, we probably want to rule out that there's still an infection or that it's getting worse, and then he needs an opportunity to get that cleared up. So after asking those questions, doing some further investigation, the result is that we've admitted him. Well, I haven't admitted him. We encourage that the family admit him to the hospital, because through that investigation, we think that he still has an active infection, and he's probably in a delirium because he has had significant changes from his baseline. And he had that cold 6 weeks ago, and a month ago, he still continued to have it. So as a result of his respiratory infection and the dehydration and weakness, so not being able to consume what he would need to keep his energy up, that he was treated with IV antibiotics, and we stabilized and returned home with more supports. So we want to keep those supports in place until we know that for sure he's back to his baseline again, and that we might want to continue with some supports going forward, just to make sure that he doesn't get into trouble again with an infection like he did at this with his history, his medical history. We would want to definitely keep an eye on that. Do you have anything to add to that, Marianne?
No, Jen, you covered that. Did a great job.
So I don't know what we're doing for time, but we wanted to provide an opportunity for questions, for any further feedback on what we've shared with you. We really did a quick overview of PIECES. We want you to be aware of what PIECES is, especially if you're a family member, if you're supporting someone with that has complex needs, if you're a staff member out there that's supporting someone. It's good to have a sense of what PIECES is about. Some of you may have the training in PIECES, and we highly encourage you to use that framework when you're trying to work with your team to discuss what things could be contributing to the behavior changes.
Thank you, Jennifer and Marianne. And again, like you said, Marianne, you had said at the very beginning, when you're looking at the PIECES, understanding dementia, it's really all behavior has meaning, right? And behavior is a form of communication. And Marianne, Jennifer, when you were sort of giving, when you were talking about the 3-question template for the PIECES, it's really, looking at it again, it's holistic. It's trying to figure out all of these different pieces that make that unique individual, and having a team approach, a collaborative approach, and coming up with different ideas and having an evidenced and an informed base approach to come up with some different tips and different strategies. I really appreciate, Jennifer, that you shared with us that, this is something that you are living, as well as helping other people to, you're teaching and you're providing this information to others as well. So thank you very much for sharing that with us today.
Yeah.
We appreciate that.
I was joking yesterday with our group that I often talk about, the P in PIECES is patience.
Very true.
Very good point.
That is huge. Approach and patience is really important, and I'm learning that definitely first and foremost. Yeah.
There are some questions that came into the chat. And so earlier, when you had talked about, some of those things that can be really important, looking at those purposeful things that people can do. So if a person happens to be, walking down the hallway, what may look like us not to be purposeful, what this one person is asking is that cart that you had talked about earlier. Can you tell us a little bit more about that? And actually, the suggestion is, how would I mention to moms, long-term care and nursing home about this cart? How can I guess have that communication with the team?
Yeah, I think the place to start with that might be to mention to the staff, do you have any recreation staff here that could give mom some tasks that would be in line with things that she would have done in her past. Because just to add to that is, I know a gentleman we were supporting in a veterans facility that the staff would say, well, he keeps opening doors and closing them and we're worried he's going to go into someone's room. But when we found out more about his life story, he was a night watchman. So that was a normal behavior that he was basically doing, that he would have done for years in his employment. So the wandering card is just that idea that sometimes it's hard to get people to sit still for a few moments, or maybe the staff are not freed up at that moment to do that. But if they have something that they can engage with, where they're feeling useful and they're feeling like they're doing something, so maybe on the cart, so it's one of the carts that they might have in the nursing home, that you might put a duster on it and ask her to go along the hallway and dust the hand railing, and then if it's time for a snack and she's not going to sit down with you, that you put the snack on her cart so she's able to reach out and eat that. So at least the cart is another way to maybe still provide that nutrition that they need and an activity that they need to still be engaged in some way. So I would start with the recreation, like the staff in the facility. And then, I mean, they can certainly reach out to the BRC team as well if there's things that we can do in collaboration with recreation to make suggestions. But the first place to start would be letting the staff know your mom's social history. Like, what are things that we could adapt for her to be able to engage with that are going to help her to feel better and feel good when she's in the facility? Because if people's capabilities and are undervalued or underutilized, that absolutely can lead to behavior. Boredom. When we're bored, we usually get ourselves into trouble, or we do things we don't want to do. So do you have anything to add, Marianne?
No, I'm sorry, I was in the chat box and I wasn't necessarily paying attention. Sorry about that.
So
But I had a couple of direct messages.
We had a couple more questions. I want to kind of get them through before we finish off today. So motivational interviewing is something that someone had mentioned in the chat as well. Is that something that you use in your work?
Not really, no. Aware of motivational interview, certainly used it in my mental health background. But no, not in this case, because, as I was saying, this is more, we work with staff and we work with care partners. So I'm not really hands-on with the person that requires the support.
Then we also have, it seems like a lot of questions just came in at the last minute here. Access. As far as accessing the supports of the behavior resource consultants. So how do we contact the BRCs for their assistance?
Okay, so if you have a loved one that is in a long-term care facility, then you would speak to the staff there and say that you would like to have us involved in a case discussion about your loved one. If you are living in the community with home supports, or if you're the care partner supporting all on your own, reach out to your care coordinator at Continuing Care and they will pull us in. And if the person is in the hospital, then it's the hospital-based care coordinator.
Excellent, thank you. So that's access through 3 different areas. So in long-term care, in the community, it would be the care coordinator. And then, of course, if it's in the hospital, it would be the care coordinator that is employed by the hospital for those people that are in hospital. Excellent. And then, do you support family residents, staff in provincially funded long-term care homes?
Say that again, Kara. Do we
support family residents / staff in provincially funded long-term care homes? Yes.
Yes.
I can answer that. Yes, I can answer that.
That we do.
And again, thank you for an excellent presentation. Thank you for your expertise and sharing your professional expertise, but also your perspective as a family member as well. So that was really, really appreciated.
If I could just chime in, Kara, we don't define ourselves as experts in any way because we know it takes a team to really try and find solutions to help support a person. And oftentimes I find that the information that family shares can often be the most useful because they know their loved one the best.
Yeah.
Very much so. Yeah.
If I have to say anything in closing out is please get to know the person and everything about the person, because it's very important for us to know that. We cannot provide good care if we don't know who we're providing it to. And our care has got to be so individualized. Teepa Snow said it the best. If you meet one person with dementia, you met one person with dementia. It's a very individualized journey that the person is going through. And you could have two behaviors that look completely identical, however, have two very different meanings for that person. So if you're not cluing in and getting the meaning of that behavior, then we're not really putting the right approach in place to support the person.
Yeah, agreed. Very much so. It's that individual approach, and that would be the other thing too. You know, if there are questions that weren't answered today in the chat, please give us a call on our dementia helpline. So the number there is 1-800-611-6345. And before you leave today, please feel free to answer the poll that our ASNS Zoom support Riley is going to be adding the poll in now. If you could answer the questions that are going to be popping up on your screen very shortly. There they are. So 3 quick questions. Please feel free to fill those out. And I want to again, thank you so much, Marianne and Jennifer, for talking to us today about the Pieces program, giving us more insight into that and how, you know, how important it is for us to be aware and how to access, how to access the service in various ways as well. Again, thank you to all of you who tuned in with us today. We appreciate your time. We appreciate your questions. And the other thing as well, we are always looking for additional ideas on topics that matter to you. So please leave a message in the chat about topics that you would like us to address and have different guest speakers coming in to speak about, and any other questions that you might have. Please give us a call on the helpline. And just to remind you as well that if you have questions, we do have a team of professionals that work through the dementia helpline and can answer any calls that you have. It's intentional, confidential support that we provide through the helpline. And just a note as well to let you know that this session was recorded and will be posted on our ASNS, Alzheimer's Society of Nova Scotia, YouTube channel. We have a YouTube channel, so there are plenty of other topics related to dementia, but please check out Marianne and Jennifer's topic on Pieces today. So again, thank you all very much. Please feel free to finish the poll, and we'll be hanging on for a couple of seconds just to make sure the poll has closed, and we wish you well for the rest of your day. Take care. Thank you all.
That's great. Thanks for having us, Kara.
Thank you.